When somebody starts out as a pelvic surgeon, probably the first thing we get to do and we walk into is the posterior wall fracture of the acetabulum. And like it or don't, it is the one fracture which has very variable results. So it came as no surprise that when I was looking to search for an article which would do justice to this journal presentation. So I chose an article by a very renowned person who has had a lot of publications other than Letournel and Jodet's work and Mata's work. And multiple presentations led him to write this review article, which is a 30-year perspective on posterior wall fractures. So what have they learned over over the last 3 decades on what happens to the posterior wall? So essentially, when they were looking to, when you're looking to appraise an article, so there are lots of questions that come to mind when you want to look at an article and see at the end of it that is this going to change my practice? So just to walk through this list, we essentially think about whether the study question is relevant, would it add anything new to our practice, what is the type of research question that is being asked, was the study design appropriate for the research question, were the methods chosen were correct and good enough to eliminate any biases, different kinds of biases that could be there. And was the study performed to original protocol? Did the study test the hypothesis? Were the statistical analysis and the tests correctly applied? And did the data supply justify the conclusions? So, and the other thing is the conflict of interest, which is very important if you see all Western presentations, because a lot of these people are consultants on different forums of different companies. So there is sometimes, that risk of having a conflict of interest. So the background of choosing of them, the authors, Buttonmore, choosing this particular of writing this particular review was that posterior wall fractures are the commonest fractures that we see. So it's about 20 to 30% of acetabular fractures. Operative treatment is indicated usually when the hip demonstrates clinical instability, which means that if you try and flex the hip to 40 degrees, you've got a hip which is subluxating outside. So those are the hips which definitely you're sure that you need to operate and you need to fix them. And the other dictum which has essentially been followed through generations since Letournel and Judet described their paper in '64 was that when in doubt, the surgeon should go in and fix the posterior wall of the acetabulum. The other things they consider are that the posterior wall fracture, essentially, if you look at the plain X-ray, may look as a very innocuous, simple-looking fracture, but there are lots of issues associated with it. So it's not so simple, and there are a lot of complexities associated with it. And what that does, essentially, is that you walk out of a surgery thinking that you've done a great job, but the actual clinical outcome in those cases is not as good as what the apparent perfect anatomical reduction claims it to be. So, and there are multiple other papers basically detailing this. So in the Letournel and Judet's series of 492 fractures, which had all types of acetabular fractures, they essentially talked about anatomical reduction percentage of 82%. And the basic dictum is that once they did a CT, the accuracy of those anatomical reductions fell to 62%. And when they added posterior column fractures, posterior wall fractures to the column fractures, again their anatomical reduction percentages fell drastically. So this was essentially an injury which was an enigma. It looked very simple, but it had more to it than it met the eye. So 82% that had of Letournel's injuries had good to excellent results, and other authors have also had very varying results, starting with authors in China like Chu, with Zhu, with Myers, Dan Myers, and even Mata has written on this extensively. And Those are essentially the consensus statements which come out of posterior wall fractures. So the basic take home, because of which the article was taken up, was that despite a straightforward morphology, posterior walls do not do poorly, and as compared to the other acetabular fracture types. So the research questions that Burton Mode asked for this before putting together this article was that how can the need for operative versus non-operative treatment be best determined? Can fixation of comminuted and marginally impacted fragments be improved? What are the risk factors for adverse outcomes after operative fracture treatment? And what is the clinical and radiographic outcome one would expect after operative fracture treatment? So coming to the first question, the first research question, how can the need for operative versus non-operative treatment be determined? So traditionally, in 2012 and in 11, and there are publications from Marvel on this in 2005 and 2001 with different authors, which essentially say that CT scan gives a much better idea. Post-operative CT scan gives a much better idea of what has happened inside the hip when you're fixed a posterior wall fracture, and in even for cases of assessment of hip instability. And the basic thought process in assessment of instability was that you look at the size of the posterior wall fragment. So there are basically the rule of 20, that if you have a posterior wall which is less than 20% of the total size of the wall, then you're probably dealing with a stable fracture. If you have a 20 to 40%, it is probably indeterminate, wherein other factors will come into the picture whether you need to operate or not. And if it's a more than 40% size of the wall, then obviously you need to operate this acetabular fracture. But experience and literature has shown that it does not work like that. It is not always the less than 20% post size posterior wall fracture which will be stable all the time, and it is and the variability with the 20 to 40% size, and 40% also was more like just an arbitrary measurement initially to start with, is not exactly a pinpointer to what and how the posterior wall fracture would behave. So there are two very good researches which the article refers to. One is by Kalkin in 88 and the other one is by Keith in 1988 as well. So first talking about the presentation from Keith, this was a fracture. This is very, very commonly the measurement criteria which was level 2. And essentially here, what is done is that the size of the wall fragment is measured at the level of the fovea. So it essentially is talking about the basically the standard posterior wall fragment. So it said that if it is less than 20% at that level, it's a stable fracture. If it is more than 40%, it is unstable. And we understand today that posterior wall fractures can maybe standard posterior walls, or they can be a combination, and so many combinations of a posterior wall fracture. So they could be extended posterior walls, they could be postero-inferior, they could be atypical posterior walls, they could be postero-inferior with lots of issues, with lots of cofactors like osteochondral fragments, marginal impactions, femoral head impactions, acetabular fractures, labral injuries associated with them, joint mouses. So this essentially was not something that was correlating with what we see on a clinical outcome basis after fixing those posterior wall fractures. At the same time, Kalkin et al. Wrote about the acetabulo-femoral index, which essentially was involving the degree of residual posterior wall intact, and that essentially said if less than 45% it is stable, if more than 65% it is unstable. So each of these methods had their own positive and negative parameters. So what Burton Moore did in their during experience, they found an alternative method, and their alternative method essentially was done at the site of the largest dimension of the posterior wall fragment. And then they said that if it's a less than 20%, the fracture is likely to be stable. It is more than 50%, the fracture is likely to be unstable, and it's between 20 and 50%, we still don't know what is the relevance. And that is where, with Grinshaw, they did a study in 2010 where you subject the hip to a dynamic stress examination under anesthesia, wherein the extended hip is observed for its congruency with the patient supine. In the same patient, if you flex the hip to 90, keep it in neutral rotation, if it is stable or unstable and congruent, if the femoral head is congruent under the dome of the acetabulum or not, and then they put an additional 20 degrees of adduction onto that flexed hip, adduction and internal rotation, and then you see if the hip retains its congruency or not. So as even Letournel put it, that the only thing that has been shown to be associated with an observable, reliable, consistent outcome for posterior wall fractures is the congruency of the head under the dome of the acetabulum. So this is one fracture where, irrespective of the size, irrespective of the status of the residual wall, irrespective of the status at the level of the fovea, the hip showed some degree of instability. So the message that came out was that as a diagnostic tool, CT alone should not be used for predicting how the posterior wall fracture needs to be treated. And the important thing is, examination under anesthesia is probably the most sensitive and valuable investigative tool that we have in our armamentarium today to assess which posterior walls need to be fixed. The next question that they answered over a period of 30 years is, can the fixation of comminuted and marginally impacted fragments be improved? Yes, because this is a subset of, this is a problem where the results of the fixation change and the outcomes of the fracture treatment change. So the one most important thing in that is, have we adequately visualized the fracture and the joint surface? So it was very important an issue when we look at the variations of the posterior wall fracture, which is the posterior superior, the atypical posterior wall, and an extended posterior where there was a combination of posterior superior and standard posterior, or a standard and a posterior inferior fragment. So the standard approach to this was the trochanteric flip osteotomy, and they said that if you go slightly anterior and choose the Gibson's interval, it obviates the need for a flip osteotomy. The other thing, the question that they asked is that sequential reduction of the osteochondral fragments and the marginally impacted fragments. And the important things they assessed here was that, yes, it is extremely important, because you have to raise them, the osteochondral and the marginally impacted fragments, elevate them so as to get a congruent reduction of the head under the acetabular dome, and then you have to fill it up with bone graft or bone substitutes, and you have to not only stabilize the defect, but you have to also fix the wall fragment on top. So as you see here, this is what they were essentially talking about. So if somebody can see the second picture on the top, this fragment has the articular surface and this is impacted inside. So the actual size of the wall includes this area of the acetabular dome, and until and unless this is raised, what we do and see from behind does not really matter. So if the acetabular surface, the articular surface is looking at the operating surgeon who's done a posterior approach, a Cocker-Langenbach approach, then this is a marginally impacted fracture and it needs to be corrected. The other thing is comminution. So if you have more than 3 fragments onto that wall fragment, it is a extensively comminuted posterior wall fracture. And some of these do have, they're large enough to have the articular cartilage fragment along with it. So what needs to be done is that one has to raise, you have to elevate the impacted fragment with the femoral head as the template, and create a contained defect, which can then be filled in by different types of bone grafts or bone substitutes. And the author in their in 3 publications have used calcium sulfates, freeze-dried cancellous allografts, and different other bone substitutes to fill this defect. And the third thing is the 2-layer fixation, which they talk about, wherein in the first layer, you have to fix the grafted tissue in the subchondral area, like you do in a proximal tibia. and that is fixed with the 2 mm mini screws or absorbable bioabsorbable pegs, and then you put a cover of the posterior wall fragment on top, and then it has to be fixed with screws and buttressed with a posterior column plate. And then the post-op CT scans, which actually will show you whether the head is congruent and whether the articular cartilage has been restored back to its normal congruent shape. So the third question they asked was, what are the risk factors after an adverse to have an adverse outcome after operative treatment? So theirs is the only series where they talk of exclusive posterior wall fractures. There have been other series of 493 patients from Letonal, from Myers of 424 patients, from Mata of 127 patients, from various other authors, where they have essentially taken up all types of acetabular fractures. So Burton Mode have basically talked about exclusively posterior wall fractures, which makes this particular article very interesting. And what they say is that unsatisfactory results are seen in cases where there is a more than 12-hour delay, and this, as of today, is questionable. So there is a large body of evidence which is starting to question this statement as well. So a more than 12-hour delay in close reduction of hip dislocations, an elderly patient more than 55 years, intra-articular comminution typically described as more than 3 fragments, 3 or more fragments, and marginally impacted fragments where the acetabular articular surface is looking at the operating surgeon. And what is important here is the accuracy of surgical reduction has to be assessed by a post-op CT that is much better than a plain X-ray, other than a very good, well-taken Judith view. Aggressive repositioning is required for the free and the marginally impacted fragments, and post-op assessment of the reduction with the CT scans. So what do we expect, and what should we expect, and what does the literature say about how the posterior wall fracture should be treated? Essentially has required the most of grading the outcomes for acetabular fixations. Functional outcome scores have not been as reliable. The musculoskeletal functional assessment is probably the one score that one can use, but it has its own set of issues. And as I said, there are different series like the Letonal and Judith series of 492 patients, the Pentapolis series, and Mod's own series of 100 patients, which have claimed a high 80% rate of good to excellent results on follow-up of more than 10 years. Functional outcomes were not so clearly defined, and complete functional post-op recovery is not the norm. And that is what was observed, that despite anatomical reduction, some of these patients do have some odd issues with activities of daily livings, and they are not perfectly back to their full functional state post-fixation. So residual functional deficits involving wide ranging of daily living are still persistent with these set of injuries. And to discuss, essentially, this was like a take-home which Burton Mode has put up and at one place, and they said that to sum it up, essentially, after urgent and timely reduction of hip dislocation, it is most important to assess the dynamic hip stability, and that should tell us actually which ones we need to fix and which ones we can conserve. And even the ones that we conserve need to be rechecked and assessed by serial X-rays up to 3 to 4 weeks before we can safely say that we have not lost reduction. And if we do, we need to fix. A more than 50% size of the posterior wall definitely needs a fixation, and anything less than that, you need to do an additional examination and then under anesthesia to decide what you need to do for that particular hip. They also said that when in doubt, it's best practice, and this has been proved by almost everyone, all the literature that is available, that when in doubt, fix, treat surgically. And probably a larger multi-center trial will give maybe a better answer on what we should do. The other thing that they say is that older patients and patients with comminuted fractures have poorer results. Underlying the key is, and this by and large is the standard consistent statement of all the 12 to 15 publications of a reasonable number of patients that have come out from 1964 onwards, that the most important thing and the most important criteria which defines how a hip is going to behave down the line in terms of degenerative arthritis and AVN is the accurate reduction and the accurate placement of the head of the femur under the dome of the acetabulum. And good to excellent results will be expected in large percentage of patients with anatomic reductions. The hallmark of this treatment is essentially repositioning and dealing with the osteochondral and marginally impacted fragments well. And every effort to recreate a congruent articular surface is absolutely justified. So more functional studies are required to justify and quantify how the patients behave long term functionally in terms of their outcomes. Thank you so much.